Welcome to Seeking Control for Moderate to Severe Asthma, the underestimated impact of comorbidities along the lifespan. This program is presented by the Partners for Advancing Clinical Education in collaboration with the Asthma and Allergy Foundation of America, and it's being broadcast simultaneously in immunologylive.com and resinsightslive.com. My name is Dr. Michael Wexler. I'm professor of medicine and director of the National Jewish Cohen Family Asthma Institute at National Jewish Health in Denver, Colorado. Today's session is interactive and allows us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time by clicking on the Interact button to the right. I'd now like to introduce my co-presenter, Dr. Anju Peters, who's professor of medicine at Northwestern University Feinberg School of Medicine. Anju?
Hello, Mike. Thank you for inviting me to this presentation. I'm looking forward to it.
Thank you, Anju, for joining me today. So let's get started. First of all, these are our disclosures. The learning objectives for a session are outlined here. Our goals are really to summarize the negative effects of comorbidities on asthma disease burden and the ability to achieve asthma control. Also, we want to explain the negative outcomes on lung development on the failure to achieve optimal asthma control in children. And lastly, we'll discuss the role of patient and caregiver preferences in the shared decision-making process and how to align treatment priorities. So let's get started. Anju is going to now start by talking about the definition and burden of moderate to severe asthma. Anju?
Thank you very much, Mike. So we'll start with the definition and burden, as Mike mentioned, of moderate to severe asthma. And this is important because we know most people with asthma do just well with the current treatment plan, but a small subset who have moderate to severe asthma, actually, there's significant unmet need, and we'll talk about this today. So the two groups whose definition I'd like to talk about is GINA, which is the Global Initiative for Asthma, and it's a worldwide group, as well as the collaboration between ATS, American Thoracic Society, and ERS, European Respiratory Society. So the way GINA guidelines define severe asthma in children greater than 6 years and older, adolescents and adults, is that once you've confirmed the diagnosis of asthma, you've made sure you've treated the comorbidities, dealt with non-adherence, that asthma that remains uncontrolled despite optimized treatment with high-dose inhaled corticosteroids and long-acting beta agonists and management of contributory factors, or asthma that worsens when high-dose treatment is decreased. The collaboration between ERS and ATS is similar for individuals over 6 years of age and older and adults. It's asthma that requires treatment with high-dose inhaled corticosteroids and a second controller and/or systemic steroids to prevent it from becoming uncontrolled, or asthma that remains uncontrolled despite this therapy. In addition, moderate asthma is defined as asthma that requires treatment with low-dose ICS and a long-acting beta agonist or low-dose maintenance ICS LABA plus a second controller. So here's a polling question for the audience. How confident are you in your ability to explain uncontrolled moderate to severe asthma to your patients? A, extremely confident. B, very confident. C, somewhat confident. D, not very confident. And E, not confident at all. We'll give you a few seconds while you enter your answers. And Mike, I'm sure you are very confident in your ability since you are a world expert on severe asthma, but it'll be interesting to see how these people respond, our audience. And I think our audience is putting in their answers. And the answer is in. The most common answer is C, somewhat confident. So everybody is at the right place. So hopefully by the end of today's presentation, everybody should be very confident, extremely confident. So not only are we thinking about how confident we are in explaining moderate severe asthma to our patients, patients have actually been polled to see how confident they are in their understanding of uncontrolled moderate to severe asthma. And the good news is over 60% touted this correctly and said that for them, uncontrolled moderate to severe asthma is asthma that shows symptoms every day, even when taking asthma medications as prescribed. There is some disconnect in a small percent, so hopefully it's at least good to know that majority of our patients think of uncontrolled moderate to severe asthma correctly. So here's a slide showing the decision tree as to how I think and how our guidelines suggest we think of difficult to treat asthma to severe asthma. So difficult to treat asthma is a much larger group than the severe asthma. In this group, the first thing is to confirm that we are dealing with diagnosis, that we're not dealing with another condition that mimics asthma. So the asthma diagnosis needs to be confirmed. We assess for comorbidities that we'll talk about later, assess for other factors, including inhaler technique. Often patients are not sure on how to use these inhalers. Adherence is a huge issue. Almost up to 50% may not adhere to their meds. We deal with modifiable risk factors such as pollutions, environmental exposure, smoke, etc. Deal with things like anxiety and depression and social issues. We optimize management and then review response after 3 to 6 months. This is best done by an asthma specialist. And if, despite all of this, asthma is not controlled, then we think of it as severe asthma. So not only do we deal with adults, which I take care of mostly, but severe asthma is a huge burden in children as well. About almost 5 million children in the United States have asthma. Most children, thankfully, have mild disease and can be controlled with low to medium dose inhaled steroids. However, about 5% of children have continued symptoms despite high dose ICS. And this accounts for up to 50% of asthma-related expenditures. So these children with poorly controlled asthma are at high risk for severe exacerbations, missing school, missing activities, healthcare utilizations with hospitalizations, ER visits, and unfortunately, permanent lung damage. Asthma rates, as I'll show you, are highest in Black, Puerto Rican, American Indian, those living in poor conditions or inner city conditions, or exposed to a lot of pollution. Here's a slide showing the asthma prevalence in children between 2018 and 2020. This is from CDC. As you can see, about 5.5% of white children have asthma, but it's as high as 12.3% in Black children. And if you look on the right side, the asthma mortality in children in 2020, this is death rate per million. The percent is on the y-axis, and you can see that it's as high as 10.7% in Black children, so quite high. This is a huge need for us to address. Here is a study that was published in 2017. This looks at the patient's perspective. So this was a qualitative study where they did a telephone questionnaire with patients and asked them burden of severe asthma. So these were adults with severe asthma from 18 to 80, and they shared their personal experience with severe asthma. Huge unmet need because of debilitating symptoms. For example, this one individual said, I have struggled with depression personally when I have been so sick, and I probably struggle with it every day now. Another individual said, I have lost in every facet of my life. So severe asthma really affects their daily activities, their sleep, their interactions with others, work, etc. Another individual said, on some occasion, the mind's there and wants to do it, but the body can't keep up, and it sort of makes you feel worthless in a way. Another person said, when my kids were young, I really couldn't play with them all that much. So it impacts physical activity. And another individual said, most housework I can't do. Can't vacuum, I can't do the bathroom or anything like that. So really has a significant impact. And in fact, severe asthma, even though it's a small percent of all asthma cases, about 5 to 10%, these patients experience outsized proportion of morbidity and mortality associated with the disease. Some of the things that we consider when we manage our severe asthma are the many comorbidities that impact their asthma control, as well as their day-to-day living. For example, if we just start in the middle, allergic rhinitis is present in many asthmatics. In adults, it could be mild, moderate, or severe. However, in children, severe asthma is often allergic. So it's important to treat their allergic rhinitis because it will worsen asthma. Similarly, rhinosinusitis, which I work on a lot, impacts asthma. It's associated with more asthma exacerbations. We'll talk a bit about EOE. GERD is very common in 60 to 80% of asthmatics, often not responsive to treatment, often can be silent. Obesity is a huge issue in asthma, and others, such as sleep apnea, goes hand in hand with obesity. Bronchiectasis, which we may see in severe asthma and may impact asthma. There's asthma COPD overlap. And then there are conditions that we cause because of our treatment of asthma with oral steroids, leads to psychiatric illness, poor coping skills, affects their asthma quality of life. Osteoporosis can lead to fractures that we may cause with giving systemic oral corticosteroids or high-dose inhaled corticosteroids. So it's important to note that these comorbidities associated with asthma need to be dealt with as well. So as we talk about the different comorbidities and impact of chronic oral corticosteroid use in moderate severe asthma, it's important to note that 1/3 to almost half of the patients with severe asthma need frequent or often daily oral corticosteroids. And in fact, 93% of asthma registry patients with severe disease have one or more condition linked to their oral corticosteroid use that has been given for their asthma. We talked about osteoporosis already, but cataracts, sleep apnea, weight gain, hypertension, which can then increase risk of heart disease, diabetes, etc. So it's important that as we talk about asthma management strategies, that we minimize oral corticosteroid use and associated risk of adverse effects that occur from steroid use. So let's talk a little bit more about asthma and type 2 comorbid conditions and the impact of these comorbid conditions on severe asthma. So here's a study done at Northwestern where we looked at patients and found that in individuals with asthma, on the x-axis, you have no asthma, you have intermittent to mild asthma, and on the right is moderate to severe asthma. On the y-axis, we're looking at sinus disease severity based on something called Lund-Mackay score. Higher the score, the worse sinus disease. You can see that many individuals with moderate to severe asthma have significant sinus disease. And this is a study also done at Northwestern. We looked at our patients with chronic rhinosinusitis, which is very common. 6 to 12% of the population has chronic rhinosinusitis. And as you can see highlighted in green, in both chronic rhinosinusitis without nasal polyps, which is CRS-SNP, and chronic rhinosinusitis with nasal polyp, which is WNP, the prevalence of asthma is as high as 36% in CRS without nasal polyps and over 50% in CRS with nasal polyps. This is a study done in Europe. This is the EuBioPret consortium of adults with severe asthma, and you could see as many as 35.4% of patients with severe asthma had chronic rhinosinusitis with nasal polyps, so much higher than what you'd see in healthy controlled and mild asthmatics. Here's a slide from impact of CRS with nasal polyp, a type 2 comorbidity in patients with severe asthma. This is from the Italian Severe Asthma Network. And in this registry, you could see in light blue is those with CRS with nasal polyps, and dark blue is without CRS with nasal polyps. and asthma exacerbation rate was higher in those with nasal polyps compared to those without. And in fact, when they looked at oral corticosteroid use, oral corticosteroid days per year were much higher in the with nasal polyp groups compared to without, and long-term oral corticosteroid use for severe asthma was higher in the with nasal polyp group in the light blue color. So it's showing you that as type 2 comorbidities common in patients with severe asthma really leads to worsening of severe asthma. Here's another study looking at type 2 comorbidities. Here you can see on the x-axis where it says M/S asthma, that's moderate to severe asthma. 60% of patients with moderate to severe asthma have allergic rhinitis. Others, 15% had comorbid atopic dermatitis, another type 2 comorbidity, and 17% had comorbid CRS with nasal polyps. What I'd also like to introduce you to is a little bit on EOE, which is a common type 2 comorbidity seen in children as well as more and more in adults. Asthma is more common in patients with the EOE than in general population without EOE. Almost 1/3 of children and adults with EOE have comorbid asthma. They have similar markers of type 2 inflammation, such as IgE, and type 2 cytokines, such as IL-4, 5, and 13. And the treatment for asthma and EOE is very similar, biologics and corticosteroids. So it's important to address these comorbid conditions, as potentially you'd improve not just the comorbid condition, but also asthma control. We do need to understand these relationships better, and hopefully we will. And this slide shows to us the different potential targets, and Mike will discuss these a lot more. When we think of the lining or epithelium, whether it be in the nose, the lungs, the esophagus, the epithelium releases alarmins that are encircled, the TSLP, IL-25, IL-33. These lead to more type 2 inflammation, which is shared by not just asthma, but many of the comorbid conditions. These type 2 cytokines, IL-4, 5, and 13, are targeted by your asthma and other comorbid conditions, treatment options that Mike will discuss, and lead to inflammation. So Mike will talk a lot more about this in a few seconds. And with this, I'd like to hand it over to Mike to discuss the importance of early asthma control, talk about uncontrolled asthma remodeling, and lung development. Mike, I'll let you take over.
Thank you, Anju. Dr. Peters, that was a great discussion about the importance of addressing comorbidities, the common pathways that are involved in asthma, and many of those type 2 comorbidities, as well as the importance of asthma severity and how prevalent asthma severity is in the general population, the pediatric population in particular. What I'm going to talk about now is the importance of trying to gain early asthma control and why it's important to try to prevent some of the inflammatory processes in patients with asthma. And that's because primarily, as I'll share with you, there's a strong potential for uncontrolled inflammation to result in airway remodeling and perturbations in lung development. So you're all familiar with what a normal airway is versus an asthmatic airway. A normal airway is open and there's minimal mucus, but in an asthmatic airway, there's reduced airway opening, narrowing, constriction, and that can result in the difficulty breathing. Obviously, the cartoon on the right-hand side, you can see that it would be a lot harder to breathe through that airway compared to a normal airway. Now, when we think about the key features of asthma, we're talking really about inflammation and bronchoconstriction. Because of inflammation, you get increased mucus production, reduced airway opening, thickening of the smooth muscle layer, an increase in the inflammatory milieu, inflammatory cells, increased mucus-producing cells in the airway in patients with asthma. The other key feature is bronchoconstriction, and on the right-hand side, you can see the tightening of the airway smooth muscles around the airways themselves that cause narrowing of the airways and would make it difficult to breathe. In an extreme case, what we could see is someone here who, this is a photomicrograph, someone who died from asthma. And you see all of these key features. You see thickening of the airway smooth muscle, you see mucus within the airway, you see influx of inflammatory cells. And this is someone who died of an acute asthma attack. So it's so important to try to appreciate all of the features of airway inflammation that are present in patients with asthma. And when we think about it, we want to address all of the key morphologic changes that occur in patients with severe asthma, whether it's the edema or the inflammatory cell infiltration, the vascular dilatation, the epithelial damage that occurs, the mucous gland hypertrophy and hypersecretion, as well as the basal membrane thickening and fibrosis. Those are some of the things that occur in an acute setting, but over a chronic setting, you may also see some airway wall thickening, smooth muscle hypertrophy, and you may eventually get some fibrosis and scarring as well. So when we think about airway remodeling, what we're really talking about are fixed changes in airway structure. You've had recurrent inflammation throughout the airways, and that can result in structural changes in the airways themselves, with resultant increased airway wall thickness, with muscle hypertrophy and hyperplasia, increase in those mucus glands, increased angiogenesis and blood vessel formation, extracellular matrix deposition and degradation imbalance. You get signs of chronic airway inflammation, and this can be seen even in mild asthma, as I'll show you in a moment, as well as reduced or delayed apoptosis. And all of these features functionally can result in fixed airflow obstruction and fixed FEV1, such that patients can no longer bronchodilate. The key features of airway remodeling and the consequences of them include the smooth muscle mass increase that can result in bronchospasm during exacerbation, the mucus gland increase that can result in mucus secretion during exacerbation, the inflammatory cell persistence that can result in ongoing inflammation, as well as the fibrogenic growth factor release that can result in collagen deposition, and also elastolysis, which can result in reduced elasticity of the airway wall. We see this in photomicrographs, and here again, this is a photomicrograph of someone who died from fatal asthma. You can see the sloughing of the surface epithelium, the enlargement of the bronchial smooth muscle, the infiltration of the mucosa by inflammatory cells, as well as the thickened reticular basal membrane. These are features seen in airway remodeling and in patients who've died of asthma. One of the other things that we appreciate is the airway epithelium gets remodeled as well. Look at the normal epithelium on the left-hand side. You can see the cilia, you can see normal structure of the airway epithelial cells, the columnar cells, and then on the right-hand side in a patient with asthma, you see complete disruption and dysregulation of the airway epithelium. One of the things that's been interesting to observe is that these changes, the potential for airway remodeling, occurs even in childhood asthma. And this is a study from about 20 years ago, which was really, really instructive. It said we need to treat asthma earlier because look at the markedly thickened basal membrane, the epithelial desquamation that's there, the goblet cell hyperplasia, the elastin deposition, the thickened basal membrane. All of these features were seen in childhood asthma. These aren't people who had asthma for decades and decades. These were in kids. So this taught us that we need to start treating the inflammation in asthma at a very young age. And one of the things that we recognize is the different trajectories of children who have asthma. These are data from the CAMP study that was published a few years ago by Dan Gold, and we appreciated different trajectories. There were some people who had normal lung growth. There were some people who had an early decline. There were some people who had reduced growth right from the start. And then there were people who had reduced growth and early decline. And it's about 25% fall into each of these categories. And this tells us that, every patient is going to be a little bit different. We want to intervene earlier. We want to prevent that early reduction in growth. And this can happen and result in phenotypes similar to COPD in a subset of patients. So one of the things that we've recognized is we can start to identify patients who have rapid lung function decline. These rapid decliners, they can be identified by presence of sputum eosinophils, but they can also be identified by the presence of nitric oxide. Patients who had higher nitric oxide levels at baseline, more than 40 parts per billion, tend to have a greater decline in their annual lung function compared to individuals who had low nitric oxide levels. This tells us the importance of IL-13, which regulates nitric oxide, in this cohort of patients over a 3-year period of time. You can see the significant decline, 43 cc's per year versus 17 cc's per year. So 3 times the decline in lung function in these patients. The other thing that we recognize is that there's these unpredictable rises in inflammation that can put patients at risk of worsening symptoms and exacerbations. Patients will have a baseline inflammatory milieu, and the maintenance therapies generally address some of that inflammation, but they may not always be enough, and you can have periods of rising inflammation that can result in breakthrough symptoms, increased short-acting beta-agonist use, and increased risk of exacerbations. So short-acting beta-agonists in and of themselves don't necessarily treat the underlying inflammation. And this has led to changes in guidelines that I'll describe with you in a moment. But it also tells us that we should be thinking about using inhaled corticosteroids, because when we treat patients who may have this disrupted epithelium, as you can see on the left-hand side, who may have thickened basement membranes, if you treat these individuals with corticosteroids, it can have a significant impact in terms of reducing inflammation and preventing the potential for airway remodeling in these patients. So putting all these things together, we now come up with an algorithm, a management strategy of uncontrolled moderate to severe asthma, both in adults and in children. And the Global Initiative for Asthma annually updates their guidelines, and they've put forth a few important sets of criteria that tell us how we should be managing our patients. First of all, they recommend, instead of just using albuterol, they recommend as-needed low-dose inhaled corticosteroid with formoterol for patients who have any asthma symptoms. You should not be using albuterol alone. In places like the US, where there is not approved as-needed low-dose ICS formoterol, the recommendations are, in fact, to give albuterol or formoterol as a rescue therapy with an inhaled corticosteroid. So it depends on where you live, but generally, anytime a patient has symptoms, they should be getting extra inhaled corticosteroids. The other important addition to the guidelines is the recognition that we need to treat the underlying inflammatory processes. In particular, in patients who have more severe asthma, we should be adding on biologic therapies to try to address the pathways responsible for those inflammatory processes. These include anti-IgE, anti-IL-5, anti-IL-4, and anti-TSLP. And this is in the most recent iteration of the guidelines. So when we think about when to consider biologics, we really want to take patients who are poorly controlled, whom you've escalated inhaled corticosteroids and LABA, patients who continue to have interference with daily activities, interference with sleep, chronic oral corticosteroid use, or at least 2 exacerbations in the prior year. Any of those patients could be considered for a biologic therapy. But before starting biologics, we want to do a few things. First of all, we want to confirm an asthma diagnosis. Not everyone who presents with asthma actually has asthma. Some of those patients actually may have tracheobronchomalacia. They may have vocal cord dysfunction. So it's important to identify and confirm a diagnosis of asthma, both by history as well as by pulmonary function testing, amongst other things. Second of all, I recommend maximizing therapy with inhaled steroids, LABA, and a long-acting anti-muscarinic agent. If the patient is still poorly controlled, we need to confirm adherence to an inhaler technique. And then, as Dr. Peters mentioned already, we want to address all the complicating comorbidities: sinus disease, reflux, aspiration, sleep apnea, as well as vocal cord dysfunction. All of these things are important comorbidities that no matter how many biologics you give, no matter how many inhaled corticosteroids you give, if you don't address these comorbidities, you're not going to take care of the person's asthma. So if the asthma is confirmed, if therapy is maximized, if adherence and technique are optimized, and if the comorbidities are addressed, Only then will I really consider using biologic therapy. So what can we achieve with biologics? Well, we have a bunch of biologics, which I'll go through in a moment, but they've generally been shown to reduce exacerbations. They've been shown to improve lung function. They've been shown to reduce corticosteroid dose and side effects. They've been shown to improve symptoms and quality of life. And to some extent, we've also been even able to induce remission and potentially disease modification to prevent asthma over the long term. Whether or not we can actually prevent asthma airway remodeling is another question that we're still working on. So first, we have a patient vignette, and let's hear Jess describe the impact of biologics on her ability to function.
I actually do work as a junior doctor in the UK, and it was during medical school that my asthma deteriorated. Like, I was spending, I think, pretty much 10 to 14 days out of every month in hospital with my asthma. And so, you know, I'd come out of hospital, would have a few days where I was pretty decent, and then I would start the cycle again where I would slowly deteriorate for the next week or two until I was back in. So at that point, you know, my life was basically just going in and out of hospital. So from that point of view, the biologics, you know, have sort of got me to a point where, you know, I'm able to sort of do some hobbies still. And, you know, like, I'm actually able to work. I finished my training, which I think none of my specialists actually thought would happen, because they were all quite shocked when I phoned up to tell them that I'd graduated.
Okay, so I think that was a really riveting discussion about the impact that biologics can have. So what are the biologic options that we can offer our patients, and what are the goals of therapy with the biologics? So right now in the United States, we have approval of 6 different biologic therapies: anti-Ig therapy with omalizumab, anti-IL-5 therapy with mepolizumab and reslizumab, and anti-IL-5 receptor antibody therapy with benralizumab, anti-IL-4/13 therapy with dupilumab, and anti-TSLP therapy with tezepelumab. We'll go through each of these one by one, but omalizumab has been shown to reduce severe exacerbation rates in patients with severe asthma. It's been shown to reduce exacerbations by anywhere from 26% up to 75% in different cohorts. In the early studies that led to the approval of omalizumab in 2003, it's been shown that in patients who have allergic asthma, there's a significant benefit of adding omalizumab onto inhaled corticosteroids with or without long-acting beta agonists. Mepolizumab was the first anti-IL-5 therapy that was approved for management of patients with eosinophilic asthma, and this was approved in 2015. It was approved on the basis of 2 different trials. One was the MENSA study, which showed that 100 milligrams given subcutaneously resulted in a 50% reduction in asthma exacerbations with a modest improvement in lung function. In the SIRIUS study on the right-hand side, mepolizumab anti-IL-5 therapy was given to patients who were on oral corticosteroids. And despite the fact that patients with mepolizumab were able to taper their corticosteroids by 50%, there was still a 50% reduction in exacerbations in that patient population. This told us that targeting patients based on specific biomarkers like eosinophils could have a significant impact. Reslizumab was the next biologic therapy that was approved in 2016 and was approved based on companion studies with this anti-IL-5 therapy that was administered subcutaneously. In this study, on the left-hand side, you can see that there was about a 58% reduction in exacerbations in patients treated with reslizumab intravenously compared to placebo. And there was also a significant impact in terms of lung function improvement in these patients. The third biologic that targeted IL-5 or its receptor was benralizumab, and this was approved in 2017 based on the Sirocco and Kalima studies. In these studies, patients who were administered benralizumab 30 milligrams given every 4 weeks or every 4 weeks for 3 months and then every 8 weeks had a significant reduction in asthma exacerbations if they had more than 300 eosinophils. And we can see here significant reductions with each of these doses, ranging from 28% in the Kalima study up to 51% reduction in exacerbations in the Sirocco study. You might say 28% isn't that high, but if you look at the placebo group in the Kalima study, you'll see that the exacerbation rate was quite low in the study, even though patients who were enrolled had a history of more exacerbations. Nonetheless, this study was quite important and demonstrated significant efficacy in patients treated with benralizumab. Dupilumab was the first anti-IL-4/13 therapy. It was initially approved for atopic dermatitis in 2017, and in 2018, it was approved for management of eosinophilic asthma that's moderate to severe in severity in patients based on the QUEST study. 2 different doses were approved, either 200 milligrams every 2 weeks, as seen on the top panel, or 300 milligrams every 2 weeks subcutaneously in the bottom panel. And what was shown was that there was a significant reduction in exacerbations in this patient population, this large study of 1,900 patients, 12 years and up, treated with dupilumab. Patients who benefited the most were those who had either high eosinophils or high nitric oxide. Patients who had neither of these tended to not do as well. And this told us again that we need to utilize our biomarkers to try to identify patients who've got type 2 inflammation. So this study was a landmark study showing improvement not only in exacerbations, but also in terms of FEV1. And the TRAVERSE study was a study that I participated in as well, that we published in The Lancet in 2022. And we found that patients who were receiving either placebo or dupilumab in the QUEST study, who were then extended out for up to another 2 years, ended up having sustained improvement in lung function. And even patients who were on placebo had a catch-up in their lung function on the order of 300 to 350 milliliters. Dupilumab has also been shown to be effective in the pediatric population. In kids who are aged 6 to 12, patients who had a type 2 inflammatory phenotype, either 150 eosinophils or more, or nitric oxide level of 20 parts per billion or more, there was significant benefit in terms of improvement in exacerbations or change from baseline in FEV1. Both of these in the pediatric population in the VOYAGE study were quite impressive and resulted in approval in the pediatric patient population as well. The next therapy that's been evaluated is tezepelumab. Tezepelumab is a drug that targets TSLP, or thymic stromal lymphopoietin, which is an epithelial cytokine. And this phase 2 study demonstrated that 3 different doses of tezepelumab compared to placebo could reduce exacerbations anywhere from 60 to 70%. What was more interesting, however, was the phase 3 Navigator study, which evaluated the reduction in exacerbations in the overall population, about a 56% reduction in exacerbations, but particularly in patients who had less than 300 eosinophils. In that patient population, there was a 41% reduction in exacerbations. Another important outcome of the Navigator study was the fact that regardless of category, whether patients had less than 300 or more than 300 eosinophils, each category, even less than 150 eosinophils or low nitric oxide, there was a substantive effect with tezepelumab compared to placebo. You can see in this forest plot, everything on the left-hand side favors tezepelumab, and also this was independent of allergic status. So tezepelumab seemed to be effective in a broad group of patients. The other thing that's been shown, and this is data that were presented at CHEST meeting, is that tezepelumab, similar to dupilumab, has profound efficacy out to 2 years. So there's substantive effect in terms of reduction in emergency room visits and hospitalizations. You can see that the rates are relatively low, but nonetheless, at baseline, nonetheless, significant reduction in exacerbations overall, 58%, but also in emergency room visits or hospitalizations, which are important outcomes. So we have another polling question. How confident are you in your ability to explain the impact of biologics to your patients with moderate to severe asthma? A, extremely confident. B, C, very confident, D, somewhat confident, D, not very confident, E, not at all confident. Give you a moment to answer. Okay, looks like the most common answer is somewhat confident, which is good. Hopefully our teachings can allow you to improve your confidence in that regard. So one of the things that's important is evaluating our patients' understanding of outcomes associated with taking biologics. In this survey of patients, many of them recognize that reduced asthma attacks and that but some people thought that there's suppression of the immune system, and a small subset of patients thought that there was increased risk of infections. We now know that with these current asthma biologics, the reduction in asthma attacks is important, but these aren't really immunosuppressant therapies, and you don't have a significant increased risk of infections for the most part. So it's important to educate our patients about what biologics can do and what they don't do. They don't suppress our immune system. They're very effective for what they're supposed to, which is reducing the inflammatory process in our patients with asthma. So what can biologics do? Well, here's a nice table outlining the overall efficacy of all the different biologics: omalizumab, mepolizumab, rozozumab, benralizumab, dupilumab, and tezepelumab. They've been shown collectively to reduce asthma exacerbations. A few of them in clinical trials have been shown to reduce or maintenance oral corticosteroid dosing, particularly mepolizumab, benralizumab, and dupilumab. They've all been shown to improve quality of life, and they've been shown to improve lung function to variable degrees, particularly dupilumab and tezepelumab. The other important thing that's important to recognize, and we talked about this before when Dr. Peters was reviewing the importance of comorbidities, is the fact that you can treat some of the type 2 comorbidities, particularly dupilumab, which has been shown to be effective, particularly effective in patients with chronic rhinosinusitis nasal polyps, atopic dermatitis, as well as chronic urticaria, and more recently, eosinophilic esophagitis. For patients with more eosinophilic disorders like eosinophilic granulomatosis polyangiitis, there's some good data with mepolizumab, which has been approved for that indication. And most recently, this past week, in fact, we showed in a New England Journal of Medicine study that benralizumab was also effective in patients with EGPA. So the biologics can improve asthma outcomes, and some of them can improve different type 2 comorbidities as well. How do we go about choosing the best biologic for your patient? Well, my recommendations are do an extensive workup. You need to phenotype and endotype your patients. You need to ask, what type of asthma does this patient have? Is the patient type 2 or non-type 2? And that's the key component here that we want to find out. We want to evaluate what type of asthma these patients have. And the way we do that is by using biomarkers. Right now, we have at our disposal just a few biomarkers. IgE can give us a sense of the allergic component. Exhaled nitric oxide informs us about the IL-13 mediated inflammatory processes. And eosinophils in the blood or in the sputum can give us a sense of the IL-5 mediated component and to what degree there's eosinophilic inflammation. Other experimental biomarkers that have been studied include periostin and dipeptidyl peptidase 4. Other people are using eosinophil peroxidase. Others are using urinary bromotyrosine. We still need other biomarkers for our patients with severe asthma. And we're still in our infancy, I feel. But as long as you check IgE, nitric oxide, and eosinophils, you've gotten a good start in trying to evaluate what type of asthma your patient has. So in terms of choosing biologics, what I recommend is, first of all, assessing the biomarkers, figuring out what's the dominant biomarker. Is there one that's really out of proportion compared to the others? Is the eosinophil count over 1,000? Or is the nitric oxide level over 200? Those would be examples of dominant biomarkers. Also, are there type 2 comorbidities that you can address? Does the patient have atopic dermatitis? Or does the patient have chronic sinusitis, nasal polyps? It's important to engage in shared decision-making with the patient because there's a lot of other factors to dosing frequency. Some medications are given every 2 weeks, some are given every 4 weeks, some are given every 8 weeks, some are given in-house, some are given in the hospital. And it's important to recognize that there's also insurance factors related to costs that can also play a role. The other thing to remember is that once you start a biologic, it doesn't mean the patient's getting it for life, and you can evaluate whether the patient responded or didn't respond. And if the patient didn't respond, you can always switch to a different biologic therapy. So when I think about the different types of patients that we see, there are a lot of different options. For instance, patients who've got allergic and eosinophilic asthma, they would benefit from basically all the biologics that we have. They could benefit from anti-Ig for the allergic component. They could benefit from anti-IL-5 for the eosinophilic component. They could benefit from anti-IL-4/13 therapy with dupilumab for the allergic component and the eosinophilic component because IL-4 is involved in IgE production by B cells, and IL-13 is involved in nitric oxide production, and both IL-4 and 13 are involved in eosinophil trafficking. Anti-TSLP is also a good option for these patients because it works upstream of the Th2-mediated pathways that regulate IL-4, 5, and 13. For patients with allergic but non-eosinophilic asthma, you're not going to use an anti-IL-5 therapy. The anti-IL-5s don't work well in patients with non-eosinophilic asthma. So for those patients, you'd consider anti-Ig for the allergic piece, anti-IL-4, 13 for the allergic piece as well as anti-TSLP. What about patients with eosinophilic asthma who are non-allergic, or who don't respond to anti-Ig therapy, or who are at a dosing range for anti-Ig therapy? Because it's only really indicated for patients with Ig levels of 30 to 700. For those patients, you could use anti-IL-5 therapy for the eosinophilic component, anti-IL-4, 13, or anti-TSLP therapy. All of those would be reasonable options. But you need to consider also patients' comfort with new agents versus older treatments, and ones that have more experience than others. But now, since they've all been approved for at least 2.5 years, I think any of these are fine from that perspective. One of the other things to consider is that we don't have any head-to-head studies of these biologic therapies in patients with asthma, and we desperately need them. The other types of patients that we might see are patients who've got non-type 2 asthma. These are patients who have absence of eosinophils, absence of nitric oxide, absence of an allergic phenotype. For those patients, we could consider giving azithromycin on a regular basis 3 times a week. Bronchial thermoplasty is a procedure that's been utilized in the past, still has a potential role in patients with asthma. And then tezepelumab, which has data in patients who've got eosinophil counts less than 150. It's the only biologic that is reduced exacerbations by about 39 to 40% in that patient population. So how do we assess our response? We're going to start a biologic therapy for these patients. How are we going to assess and evaluate response? Well, we have to look at different outcomes. And the way I think about it is, what was the reason I put the person on a biologic to start with? Was it because they were having exacerbations? Well, did they have a reduction in exacerbations? Was it because of their symptoms despite use of all therapies? Well, how are their symptoms now? What about lung function? Was their lung function low and did it improve? What about the biomarkers? Did they improve? Then you have to ask, well, not everyone's going to be a complete responder. There are some super responders who respond in all these different domains, but there are some people who respond partially. And then there are the people who've got to respond and they have sustained response. And those patients, we say, are entering remission. What's remission? Well, remission is really a state or period with little to no disease activity that can be spontaneous or it can be a result of the biologic therapies. We characterize patients as having remission if they have no exacerbations, no oral steroid use, no significant symptoms, normalization or stability of lung function, as well as stability of the type 2 biomarkers over a 12-month period of time. And many of the therapies have been evaluated for these things. So this is a nice study that we published in CHEST, Najura Lagogo. We reviewed the different remission criteria that we published in CHEST this past year. And we found that most of the biologics were able to achieve remission in a subset of patients. They were able to get patients to have an ACQ less than 1.5, or they were able to achieve normalization of lung function, FEV1s greater than 80%, and have no exacerbations and no oral corticosteroids with dupilumab, benralizumab, mepolizumab, and tezepelumab. All these therapies have been shown to achieve efficacy in that regard. But remission was achieved in only 8 to 38% of patients, depending on the definition used. So while remission is our goal, we still have a far ways to go in terms of evaluating which patients are most likely to achieve remission and benefit from each of these specific therapies. In summary, targeted biologic approaches to treat asthma have been shown to be safe, and they're approved pretty much globally, some for multiple conditions. Dupilumab is approved not just for asthma, but also atopic dermatitis, chronic rhinosinusitis, eosinophilic esophagitis, prurigo nodularis, and probably eosinophilic COPD in the coming year as well, based on data there. Omalizumab, the anti-IG therapy, is also been approved for chronic spontaneous urticaria as well as nasal polyps. Mepolizumab has been approved for EGPA, HES, and CRSNP, and there are ongoing studies with benralizumab, reslizumab, and tezepelumab, and these therapies have been approved around the world. The other thing to note on this slide is the ages. So dupilumab, omalizumab, mepolizumab have all been approved down to age 6, benralizumab and tezepelumab down to age 12, and reslizumab is only down to age 18. And lastly, the other thing that differentiates these therapies is the frequency of administration, every 2 weeks to every 4 weeks, and for benralizumab out to every 8 weeks. So think about all these things as you choose the biologic therapies for your patients. One of the things that we've recognized is that biologics can make a big difference for our patients. We have a lot of options now, which is great. I think about 10 years ago, we really had only one biologic option. But as we've talked about, choosing the best biologic can be challenging. We do need to do some head-to-head studies, but our goal should really be to get our patients into remission, to having a super response to these biologic therapies. If the response is incomplete, we could consider switching, and we're also looking at maybe even adding on biologics, different biologics onto patients. And then, can we give therapies earlier on to prevent airway remodeling? I showed you all those slides earlier of the potential of developing inflammation resulting in airway remodeling, even in the pediatric age range. We need to treat those patients definitely with inhaled corticosteroids earlier to prevent all the damage to the airway epithelium and to the submucosa. But maybe we should be giving biologic therapies to our patients with severe asthma. What I'm excited about is that we now have many new drugs on the horizon, and there are a lot of novel therapies that are being investigated. Some are longer-acting versions that only need to be administered every 6 months, maybe even once a year in the future. So that's really, really exciting to me. And I think it's important to have newer options that work a little bit better and that are quite effective for the management of our patients with severe asthma. So thank you so much. We have some time for some questions. I see that some questions have already come in. Let me just pull open the question panel. Hold on a second. I don't know if Andrew, if you can open that. I have to figure out how to do that again. Let me see. Here we go. Here's some of the questions. All right. So let's see. Some of these came in as we were speaking, but there's a bunch of questions that have come in. So, which biologic has the fewest side effects in children and in adults? Andrew, do you want to handle that?
Well, absolutely. Obviously it's a big concern. Safety is a big concern, especially with children. So we already know that one has been around for almost 20 years, which is omalizumab, which is approved for allergic asthma. So that has a very good safety record. And then dupilumab has been studied in children also. It has a very good safety record. All of these biologics actually are very safe. None of them are immunosuppressant. They have a few side effects, but the ones that I tend to think of using in children is omalizumab and dupilumab based on the data, but all of them are very safe.
Yeah, I agree. I think they're all generally very safe. It was omalizumab. There's a potential for anaphylaxis in a very small group of patients, and so you just need to be cautious and cognizant of that. With mepolizumab, there's potential risk of zoster, herpes zoster, and also with dupilumab, there have been some reports of patients getting a conjunctivitis in a subset of patients, particularly those with atopic dermatitis. Another question, what biomarkers are useful for monitoring response to biologic treatment in patients with moderate to severe asthma? Yeah, so I think it's most important to monitor patients clinically, but I generally do follow from a pharmacodynamic perspective eosinophils and nitric oxide for patients who are getting some of those therapies. We want to see patients who are getting an anti-IL-5 therapy. We want to make sure that their eosinophils come down. For patients who are getting dupilumab, we want to see that their nitric oxide levels come down. But those are the key things. IgE is not a great biomarker for response to anti-IgE therapy, so that's important as well. Are there any comparative efficacy and safety data for biologic treatment of asthma? If not, are there trials planned? There aren't really any good head-to-head studies in that regard. There's some indirect studies. They don't have great data, and depending on who designed the analyses, might choose one therapy over another. So I wouldn't, right now, we do need comparative efficacy data. Safety, they're all pretty safe. How common is COPD in children? Well, I'll start off answering that. I think, first of all, COPD generally implies emphysema and chronic bronchitis. Now, we could see some of the features that might be seen in COPD patients in some patients with severe asthma. But generally, I wouldn't say that any child gets COPD. Theoretically, if they have alpha-1 antitrypsin deficiency, but that usually manifests itself later on in life. Andrew, I don't know if you have any other thoughts in that regard.
No, you'd be the COPD expert. I know we got a couple of questions on safety, and again, we'll just echo what you said. They're so safe. Some are approved. Dupilumab, omalizumab, and mepo are approved for children over 6 years of age. Tezi is approved for over 12, and resizumab for over 18, and Benra for over 12. So it tells you that these drugs are very safe, and I think that's what I would take away.
Yeah, good. Another question, how long are biologics used? Most of the studies in the pivotal studies were given for a year, but there have been long-term extension studies out to 5-6 years now for some of the studies. And we now have experience with omalizumab. It's been available for 20 years. We have some patients who've been getting it for 20 years. Mepolizumab was approved in 2015. We've been getting patients who've been having it now for 9 years, or 8 to 9 years. And then each of the other studies has demonstrated efficacy out to 3, 4, and 5 years. So another question would be, how long should you use it for? I usually keep patients who are on them for a year, and then we have discussions that involve shared decision-making to help us decide what the best options are. We're running close to time, but we'll try to answer a couple more questions. People can drop off as needed. What's the best biomarker for monitoring response to biologic treatments in patients with asthma? Again, it depends on the biologic and the specific biomarkers. Eosinophils for the anti-IL-5s, nitric oxide for dupilumab, and you can look at either of those with tezepelumab. Are there any comparative efficacy and safety data? No, I think we've looked at that already. We have just a couple more questions. Have any clinical trials showing efficacy of biologic for asthma also shown improvement in comorbid conditions such as atopic dermatitis, chronic sinusitis, nasal polyps, or allergic rhinitis? And the answer to that is yes. I think Andrew showed some data before, but for the drugs that have efficacy in asthma, in which patients had chronic sinusitis, the chronic sinusitis improves, and for chronic sinusitis studies in patients with asthma, the asthma has improved as well. We've seen that with omalizumab, mepolizumab, dupilumab, and to some extent we're seeing it with tezepelumab as well. And certainly the atopic dermatitis improves in patients with dupilumab. Why and when should nitric oxide test results be interpreted with caution? I think, when nitric oxide levels are really low, I think that's helpful. When nitric oxide levels are above 50, that's helpful. When they're in between 25 and 50, it's hard to interpret some of those results.
I think sometimes like allergic rhinitis will show higher FeNO, so it's important to consider that too.
Yeah. Should patients be tested for TB before starting biologic treatment? That's currently not a consideration. These are not immunosuppressive therapies, and there's no risk as far as we know of reactivation of TB in those patients. And then the last question is how to define incomplete response and how early can we switch to another biologic? So incomplete response really is patients who go from 4 exacerbations to 2 exacerbations, or have some improvement in lung function, or can taper their steroids from 10 milligrams to 5 milligrams but not come off. So those are people in whom we consider there to be incomplete response. So those are all the questions we have. I want to thank you, Dr. Peters, and also thank our audience for the great questions. I also want to thank Regeneron and Sanofi for their support of this important educational activity. I want to remind people as well to complete the post-test at the end of the session to secure your CME credits, and also to please visit immunologylive.com or resinsightslive.com and to view today's session along with other sessions on demand. Those websites are listed over here, immunologylive.com and resinsights.com. But I want to thank you all for joining us. Thank you. It's been a great questions from the audience, great discussion, great presentations by Dr. Peters as well. So thank you so much for joining us, and look forward to doing more of these educational events online. Thank you.
Thank you.